Geoffrey Anguyo is a general practice physician trained at Makerere University Medical School in Uganda with an interest in innovative and sustainable approaches to community health and global health education. He is the founder of and executive director of Kigezi Healthcare Foundation, KEHEFO, a non-profit organization based in the southwestern part of Uganda. Dr. Anguyo is also the medical director of Child Family Health International's Ugandan Global Health Program and supervisor of Community Placement Program with the Mbarara University of Science and Technology Faculty of Medicine and Department of Community Health. In August 2018, he was elected as a board member to the Governing Council for the Uganda Society for Health Scientists. We're excited to have Dr. Anguyo here today to discuss multidisciplinary approaches to overcoming high disease burdens in low-income countries with an emphasis on lessons from Uganda. Please join me in welcoming Dr. Anguyo.
Good afternoon.
Good afternoon.
This is my second time to be here. In Africa, we always start by bridging that gap, greeting, and then if you visit people and you greet them and then they don't greet you back, it's like you are not welcome, so I just walk out. So I'm happy that you have welcomed me here and having a very nice lunch, the American, the salad, the sandwiches, and the rest. I think we have had a number of students who have come from here to Uganda. Some of them, the recent ones are here, the old ones are here. So it's a very good mix of alumni. And then we are looking at how do we go ahead with this kind of partnership and then engaging more faculty members, probably in research. We have partnerships with over 50 universities in different parts, University of Toronto and others. Every year I travel. Actually in the US, I've so far visited 42 states. So many times I talk to people like, you know US more than us. So every university that sends students there, when the students come back, they share their experiences and they always want to go back, and then they share with the others, so it keeps attracting more universities. And then we have partnership with Child Family Health International that also promotes our program, and many students like applying, going to Uganda through that program. So it's part of what I'll be sharing. Kigezi Healthcare Foundation, you can see that is the English. Being in rural, whenever you come up with an initiative, you look at the international community and also the local community. If I put the name in a local dialect, then you people will get lost. But then KEHEFO, just it means KI is Kigezi, HE is healthcare, FO is foundation. Now when you go down to Uganda, you talk about Kigezi Healthcare Foundation, people don't know what you are talking about. But when you talk about KEHEFO, everybody knows. So when you go, you talk about Dr. Geoffrey, they say we don't know this American. Then when you talk about Dr. Anguyo, everybody knows. So these are some of the, cultural issues. There's just some introductory video. Does it work? We are testing and there is too much technology involved. We are still more analog, so most of the work you use drama. So, but here everything is filmed and it is on YouTube.
In Africa, and in Uganda in particular, we have had a long-term challenge of poverty, disease, and ignorance.
It's a big problem. That is a national issue. Whenever I tell people what I'm doing, they say, no, you are mad, you can't do this. I said, yes, most of the things are done by mad people, so it's fine. Geoffrey started around the year 2000. By then, HIV/AIDS was out of control. First, I was working in a government hospital. The resources were not enough. At times, you see people die where you could help, but you can't help, and you have no power to say, let these resources be there. I felt I was not doing enough to help these people. So I started my own private clinic. Initially, this was not to start an organization. The initial focus was to help people.
I had my two brothers who were HIV positive. So they were so weak, we almost lost them around 2002. One who died last year, 2010. Another one who died in 2009. I believe Geoffrey sustained them to live to that moment.
I've lived with HIV and AIDS for some time. It's about now 10 years. I first came as a patient. I couldn't even eat. I couldn't walk. But now you see, I'm okay.
My sister was able to accept that she's living with HIV and AIDS, and that living with HIV and AIDS is not a death sentence.
Because of the corruption that we have here, government hospitals at times they have no drugs. Patients opt coming to Geoffrey where they get the service. Some come from 20 miles away from the town.
When they have the disease, you must treat the disease. Then as you treat the disease, this disease has a cause that is preventable. Disease, poverty, and ignorance are interlinked. And you cannot handle one without handling the other. So with the time we had to refocus the way we work. We have to go back to the community. Geoffrey started with 3 people, but the number kept growing. 10 years later, we have a total cumulative number of about 6,000 people registered. I can say Geoffrey started as a clinic, but now it's a development organization.
The kind of patients that come to Geoffrey are those who are HIV positive. Others are those who have children that are malnourished.
We take out medication to people who can't afford to come to town. We have a program for malaria prevention. Then we are going into maternal health. Maternal mortality is very, very high still, and it needs to be addressed. Geoffrey has gone into one issue after another. Whatever issue comes out, we just take it up. As you're educating them, at the same time you also empower them how they can generate income.
It's because they don't even have the capital, maybe to start up some businesses or to have some income generating activities that would help them to improve their livelihoods.
Most Ugandans are based on agriculture, and that's the best they can do since most of them are not educated. Geoffrey decided to go to the grassroots by providing agricultural inputs.
We have been in touch with her for the last 4 years. All her children died, and then she had 3 grandchildren. So we gave her 2 goats. We needed 2 goats to pay school fees for 1 year. Now they are 5. By the end of this year, they will be 7. If you empower a family, a household, they have their own income. They should be able to send children to school, buy medication, provide the balance there, and that empowerment will really give us fulfillment. We get satisfaction.
People really see Geoffrey as an organization that is growing and that is going to bring more services to them.
Traditionally, doctors just sit in their clinic and wait for people to come. But my dream for Uganda is for all doctors to reach out to the community. We are looking at this to be a model for Uganda, then eventually for Sub-Saharan Africa.
It may be in the near future we'll get a generation rid of HIV and AIDS. We don't know, but we hope so.
Now a Ugandan knows one day I can also have income to build my own house. I can have income to sustain my children. People are getting hope.
Feel happy, when people appreciate, when people feel happy, that's part of the excitement. And it's a motivation, it motivates you to work more.
Geoffrey does not belong to one man. It belongs to the society, to the community. It is actually an organization of the many.
The Geoffrey gives them a lot of hope, and they are putting all their future in Geoffrey.
Back to the tech. Actually, the person. The person who shot this film came from California. California is part of Hollywood. For him, it was like he doesn't have physical money to give us, but he can, use his skills to do this. I think this video has promoted us so much in the last few years, and everywhere I go, people just tell me that video on HIV is great. But then, to do this kind of, and this video has, given rise to a whole department of filmmaking. We have young people making film, they are being trained in making film. So some of the things that look small, eventually, they grow big. That is Uganda. Many of you may not be conversant with countries in Africa. Africa has many countries. Uganda is in the eastern part of Africa. All these surrounding countries, East African communities becoming like one state. So it's more or less like USA. You can go to Kenya, Tanzania, Rwanda, Burundi, South Sudan, if you want to stay there, if you want to work there. So there's free movement of people, free movement of goods. Students move anywhere in any of those institutions, universities. So we have that integration. Now we have one passport. The next will be monetary union. We'll be having one currency. So the future is to have one president. But when that one will happen, I can't guarantee. Others are happening, but that one is for the future generation. This one helps us a lot because all our guests now, I think 95% of our guests land in Kigali. That is the program site where you see the star. From Kigali to that site is 2 hours drive, but if you fly from Kampala, it's about 10 hours. So when we are always communicating with the guests, we're like, you can choose either to travel for 10 hours or 2 hours. The decision is yours. We are making 20 years, and as part of 20 years, we are going to have many sites eventually. We are preparing communities in different parts of the country. Ministry of Health and a number of other partners really want this organization to have a national picture. But then we don't have to open offices, like all over the country. We just have to get partners that are effective. They come look at what we do, and that's how we'll be working. So it's not about creating a giant organization with offices all over the world, but then it is creating partners who are effective and do similar kind of work. So we really want to look at many, if you look at a lot of international organizations, huge, giant, and then administrative costs are like 70%, and then, they have always got a lot of criticism. A lot of money goes into the administration, paying people, buying huge cars, so we want to avoid that. We have read a lot about that, so we're like, moving forward, as we expand, we just get partners and work with them. There's no need to start opening offices all over. So That is the strategy. We have a huge population, and I think Uganda has one of the highest fertility rates in the world. So we are trying to look at how best we can control that. You can say life expectancy is low, and we have more, about 60 to 70% of the population is young, 20 years and below. So now you can see you have that big youthful population. Now, this is one of the key aspects. It gives you a picture of how our health system works, especially if you're in global health, public health, even any other health aspect. That's the policy, that's designed by the government, and that's what we all follow. We have level 1. Level 1 is community, village level. It doesn't have any physical infrastructure, no health buildings. We have community health workers, we have community leaders, we have community volunteers. Any responsible person who is willing to deliver, give out health message is part of level 1. So level 1 focuses on primary health care. Primary health care is education, more about talking, family planning, HIV/AIDS, maternal health, malnutrition. It's just talk, give the right information to people. It is preventive. But then the moment someone tells you, I have a toothache, I have a headache, I have a backache, that's the end of primary health care. So that's when primary care starts. So now, if at lower level 1, people complain, we have this problem, then we have to refer them to level 2. Level 2 is where you have the physical infrastructure. A new curriculum was developed where you have nurse practitioners. There are treatment guidelines. Nurse practitioners can, take basic history, examine, and look at the kind of problem the person has. And according to the treatment guidelines, they are allowed to make prescription for, basic malaria, if there's a respiratory tract infection, which is like 1-2 days, some small cuts. So a lot of things, but then technically it is a triage center. So the nurse practitioners will be able to know, does this person have diabetes? Does this person have high blood pressure? Because they have blood pressure cuffs, they should be able to check. So it's more of a triage center, so that, advises a person where this person can go. So then from level 2, you go to level 3. Level 3 is bigger than level 2. Level 3 has a maternity center, has midwives. So all the women who come for antenatal care, prenatal care at level 2 are referred to deliver at level 3. So level 3 has midwives, also still has nurse practitioners, clinical officers. Now, clinical officers, clinical medicine was introduced. My training was in clinical medicine and surgery. So I performed clinical medicine and surgery. But then it takes a lot of time and resources. So eventually a decision was made. It's a curriculum adopted in the whole of East and Central Africa to train people in clinical medicine without surgery. So you take less time. It's infectious disease, non-communicable disease, all conditions that don't need surgery. So clinical officers for us, they are like front line. They are the first. So they see a lot of patients. So they run most of the outpatient departments. So all these infectious diseases, what they can manage. And then there's a level 4. Level 4 was introduced mainly to contain maternal mortality. Maternal health, maternal death is very high, mortality. Activists put it at 16 mothers die every day due to birth-related complications. That's a lot. So level 4, there's a small operating theater. Level 4, there's a small operating theater. It is meant to take services closer to people. So which means if a woman comes with obstructed labor, then she will be able to be operated at level 4. Then level 5 is a traditional hospital that used to be there. You know, it's bigger, maybe it has 200 beds, it has more doctors. So we are looking at if level 4 gets overwhelmed, then they send some of the patients to level 5. And level 6 is when you start getting the first specialist. That's the regional referral. So where you have a pediatrician, you have a gynecologist, you have a psychiatrist. So that's how it works. And level 7 is super specialization. Actually, this year they introduced level 8. Now, level 7, level 8, they are all in Kampala, where you have Heart Institute, Cancer Institute, Lung Institute, it's highly specialized. So now, if you look at this structure, technically, people at higher level are supposed to go to lower level. It means if you have people who have psychiatric problems, let's say level 3 or level 4, so you expect psychiatrists, you make appointment to expect psychiatrists to come and see them. That's how it's supposed to work. But then, practically, patients are being pushed, upwards. It's like people just want to get rid of, what you see, say, go to the next level. Then go to the next level. And then most of these levels where people have not yet gone to, very many people have not gone to the capital city. And then by the time they tell you, your problem is you need to go to Heart Institute. It is in Kampala. They go back home. That's when they go to the traditional healers. The traditional healers, try to give all kinds of herbs they can. They go to the religious institutions for prayers when it is congestive cardiac failure, when it is uncontrolled diabetes, when it is HIV. So now our approach is we go to level 1. So we are the only organization that runs clinics at level 1 at the community level. So you get involved in primary health care, at the same time primary care. You talk to people, there's a group educating, and then people who are sick, we also set up clinics. So at level 1, people get high quality health care, dental, you screen people for cervical cancer, for prostate cancer, for diabetes, for HIV, all kinds of, health care. We do it at level 1, and that's what is very popular with students. Now, eventually, if you look at this, we started as an HIV organization. If you look at just the summary from the video, with the 3 patients, and then the number went like up to 6,000. A small clinic, a whole street gets jammed every day. So the first thing we had to think of, how do we help this situation? So now we opened the satellite clinics in the communities. Initially, they were HIV clinics. So when we opened the satellite clinics, then the whole street became empty, People rather go to the clinic we have set near where they can move, other than all coming to town. Then when we are going for these HIV clinics, definitely if you're a scientist, you always have to ask that question, why, where, you have to ask. Then you see a woman coming with 6 children, has come to HIV clinic, but then you have to ask, you have to have other observations. That's what I tell students. A woman comes with 6 children, say, why are you coming with 6 children? I don't have anyone to look after them, so I have to come with them. So now, if a woman comes, then you say, how many children do you have? 10. Then you ask another one, how many children do you have? 7. How old are you? 25. Oh, then there's trouble. So family planning. We have to introduce family planning. Now, family planning, initially we realize also when people will eventually mortalities, infant mortality even has come down. In Africa, people used to produce a lot because you are not sure how many children will survive. Infant mortality was very high. I think my maternal grandmother, she always tells me she produced 14 children and only 2 survived. My mother is one of them. So that's how bad the mortality was. So the issue was about not limiting the number of children. So God knows how many will survive. You produce as many. But then people are realizing with all this immunization, development, a lot of things are taking place. People are also realizing children are not dying like they used to. So there's a need to embrace family planning. So actually when you talk to people, people need family planning. But then it's the same trend. They keep saying, go to another level, go to another level, which becomes hard. So when we go to the community, all these services, we do HIV testing. If someone has 6 children, said, I have enough, you just provide the family planning there and then, long term, So you have these implants. So when you go to communities, you provide all these services at a lower level. That's what has made our program successful. So you can see all dental health, all these others get integrated. And then of course, people are poor. Then you have to, how do you get them out of poverty? Because we have seen people getting out of poverty improves the health outcomes. So now, enterprise development is one of the activities we do. Enterprise development is about exposing people to different skills and let them choose what they think they are best in. I like putting on these fabrics because they are made by women, young girls, young boys. That's where they think their skill is. We introduced the Rabbit Project. Rabbit Project is very successful. Now, why did we introduce Rabbit? World Bank and Uganda government sat and introduced the chicken project. Giving chicken to poor people. And now here we are looking at poverty, people living on less than $1. Chicken, you have to keep them in the house and feed them. If you can't feed yourself, how do you feed the chicken? That's not rocket science, that's common sense. That's how World Bank fails. A lot of money is injected. People are not asked. So we have held that discussion and say, if someone is a vegetarian, how do you bring 10 pounds of beef without asking? Are you a vegetarian? First ask. World Bank is not asking. They say we are doing needs assessment, feasibility. You see, they do desk reviews. They sit on the desk and analyze documents all over the world and then come with the best model. It always fails. So now, when it failed, actually it's good, we are happy. It was the first time our government apologized that we have agreed that we have failed. So that's how we came with the Rabbit Project. Rabbits eat grass. Who buys grass? It is everywhere. So some of these projects, to succeed, it needs common sense. It doesn't need rocket science. That's why, how do we partner? And that's what we tell students. I tell them, you come to Uganda to learn things you can't Google. If you can Google, you Google them from Princeton. You don't need to come to Uganda. But there are all these experiences you have to get exposed to. So now you can see this, we had this nutrition rehabilitation center. Now you see these kids, swollen, that is protein deficiency, no protein. And children are given potatoes from January up to, the local person knows it is full tummy. But what is the quality of that food? So we have reduced malnutrition by just telling mothers, telling parents to mix potatoes with vegetables. You know, people have low perception about vegetables in Africa. They are all over. The place is green. So they think vegetables are useless. They cause worms, they bring sickness. When in America, vegetables is for the rich people. I always give people that example when I first came to US around 2007. There was a conference in Denver. And then at the end of this conference, they served the dinner, salads. Then someone stood and gave a speech. It was a very nice dinner. Then to me, I was like, where's the meat? So you see, I also had that perception. So if I have that perception, what about the rest of the people? So it's the perception we have to change. And that's where, you know, film, if you look at the model. So you make films around these themes, and then you take to the communities. So we have a lot that students can do, and we have a lot that we can do with the faculty members. So as more students keep coming, how do we also engage faculty members so that we can effectively, you know, address some of these issues? So these are just a few other promotional activities we do in the communities. Top 10 causes of death. Most of these you can find in the literature. So we have dental clinics. We provide integrated health care. Then we get support from different partners, because one of the things we are looking at, how do we provide quality services? So we partner with many organizations in training our health workers, because when you get a donation of equipment, you also need training. So one of the things we do is scholarships. People go for different courses: nursing, medicine, imaging, dental. So that's what we do. It's a lab. But then when we go to the community, we have a smaller version. And then, of course, if you know there are some other conditions that you need more investigations, you collect samples, you come and analyze them more back at the center. Now, students help us a lot. You can see a whole room like this is medical records. And the issue is, how do we go away from? Because about 90% of our nurses don't know how to use computer. So how do we address that? Because every time people ask me, what kind of people do you need to come? I say, no, the condition to come to our organization, you only need to be alive and breathing. You can do anything. I mean, all these records, actually, a lot of it has reduced because students at times spend the whole night, you know, entering some of this. Then, like, in the future, we need to get this data direct into the computer, you know, not first in the paper, then you wait for people to get them into the computer. These are some of the areas of partnerships. If we are to do research, how can you, you know, have a questionnaire on the tab or on a smartphone? Many people can now use smartphone, but they are not yet easily affordable that side. So these are some of the areas of collaboration we need so that we can see how we can effectively address this. Infant mortality, maternal mortality, of course these are official figures, and most of these figures are projected from deaths from hospitals. So when it comes to reality, our communities, you don't report deaths. People die in the rural areas, they just bury them. So, but then whatever is official, we always talk about the official. So you don't have to create the unofficial. The only way you can bring out another one is when you carry out independent research. So we still rely on what is official. So we have the maternity. Of course, very many women deliver with the traditional birth attendants. Now, many times when you talk to these women, because a number of these health units have like one delivery bed, many women still deliver on the floor. So some women, if I go to the hospital, I still deliver on the floor. If I'm at home, I still deliver on the floor. So what's the difference? So now we have a maternity center that has like 6 delivery beds, and very nice, clean. So when poor women really come and see that they can deliver in a very good environment, so it's pulling very many of them to come to deliver. We first started by using portable ultrasound. We came up with a concept, so using portable ultrasound to attract women to come for antenatal care. The number increased like 3 times. And now we are still using fetoscopes. I don't know some of you who are health workers. A fetoscope is just some rudimentary gadget you use. You know, you put on the tummy of a pregnant woman to listen to the fetal heart, and you must have the skill. But then ultrasound technology is becoming popular. You know, people watch on TV. They know that if you can go to the ultrasound, you are able to see your baby. So it's popular. So we wanted to test that. And when we tried, so many women were turning up for, because they were not paying. So that one was published in the journal. We eventually will share some of those links. And then actually the ultrasound machines were loaned by Sonosite. Now when it appeared in the journal, then they said, oh, you can keep them. You see the importance of publicity. And then when it appeared in the journal, New York Times also published. So when it came to New York Times, then they said, oh, we can give you 2 more. So that's why we need partnership with some of the faculty members. How can we promote some of these small initiatives? You know, you design a scientific way of collecting data and it get published. That is what is happening. So I always tell students, when you come back, make noise. And publication is official noise, you know. So official noise becomes musical and people all dance to the tune. So we have different programs. This one is a delivery kits. Many of these women deliver in rural areas, and there are delivery kits on the market, but they are expensive. So we have come up with cost-effective way of making this, and they are popular. So we are trying to look at how they can be rolled out. And you see the other side, those are politicians, high-level politicians who are surprised that we can do that. Said yes. So that was it. When we have some functions, government functions, we also go and do exhibition. It is local, like publicity, so that they get to know what we do, and they leave us to work comfortably. So you can see the nutrition center is no longer like it used to be. We used to have severe cases like that, but now the clinic, we don't get very many severe cases. Most of the cases, because we go to the communities, we address them before getting severe. So these were the early stages, but now most of the cases, we address them before they get severe. So we run rural nutrition screening clinics. So now you can see many kids come. It is popular. So families where we have given rabbits, then you have to go and also screen the surrounding families. So it is where we take students. Students can get involved in this kind of activities the whole day. So these are the rabbit projects. We have down in the center, you can see very many people come to learn. These are groups coming from different places. You know, how do you breed on a small scale? How do you breed on a larger scale? So we have a breeding center. And then those are innovations, you know. You go to the communities, you find people are trying to use their own local resources, you know, to rear rabbits. And they are doing it well, so it is encouraging. So typical community outreach, where you go into the community, arid communities, so with the different partners, there's a lot of teaching going on of our health workers, international. So this is a partnership with the University of Toronto. They get dentists practicing and also faculty members. Then they come with the students, with our Ugandan students. So all those equipments are left for us, so that when we go to the communities, if there are cavities, we feel. Now we have moved away from extractions to, you know, feeding, even making dentures. So that's the kind of work we are doing in the communities. Recently, we are piloting using smartphones, you know, ultrasound scan using smartphones. So it is becoming popular, but in this one we are still piloting. Yeah. Cervical cancer screening, we are partnering with the Rotary clubs, and a lot of data. We can do a lot of publications in some of these areas. So these are apartments where students stay. Some of you are like, oh, how do you stay in those other huts? So the places are nice and conducive. This is our newest project now. You can see when we go to the communities, especially, you know, with the students, we hire, like, you know, 5, 6, 7 vans. It's expensive, and we sat down, we looked at this bus can carry like 50 people, between 50 and 60. It takes all the supplies, everything at once. So it will help us to reach out to more communities and more frequently. So the cost is $100,000, and our slogan is, how do we get 10,000 people to donate $10? That's the slogan I leave you with. Because I was I was with the SafeHI, so all our partners with the SafeHI, they have jumped into that bandwagon. So all the money that is collected is sent to SafeHI, so that next time when students come, we don't get headache, all of us get in. So it is the hottest program on table now, and that is the noise you have to keep making now from now. We need 10,000 people to donate $10. Thank you. Any questions?
Okay, so as usual, we have time for questions and answers from the audience. So would anyone have a question for Dr. A? Go ahead.
Okay, so thank you very much for this. I'm interested in how technology drives the partners that you're looking for. So how your idea of the ideal technology to help your project drives your search for partners.
One, you see, high-income countries are now driven by technology. Where low-income countries are still sticking to the old methods. But then you can see the one example I've given you where portable ultrasound has increased the, you know. So now you can see some of this technology is needed because it catalyzes change, you know, it brings rapid change. A change that will take like 20 years can happen in 2 years. You see, that's a typical example. And then of course, it may not necessarily be about technology. Now, like the Rabbit project, it's not about the technology, it's about local initiatives. But then all this technology, because filling cavities in the teeth, you don't have any local method. Actually, if you don't have the technology, you just have to pull out the tooth. So now you can see some of the technology is necessary for us. Otherwise, without it, we'll keep on our old rudimentary methods and we remain stagnant. So now, if you look at all this equipment that is brought, our people are trained on how to use them. And then instead of pulling the teeth, you conserve. You see, you keep filling the cavities, so you protect people from losing teeth. You do screening early for diabetes, for cancer. That screening, there's some technology needed. But then when we employ that technology, the output is rapid.
Right, so does this do anything to, does this reshape or change in any way the kinds of alliances and partnerships that you're seeking for?
It doesn't change, because to us it is one, you know, we have our interests, you also have your interests. Now, our partnership with the universities, you see, universities have two main objectives. Teaching, how do students learn? Then research, how do you create more, you know, how do we get new knowledge? The moment you have those two, then you are very good friends with the universities. That's why we do serious teaching. These students can testify, they learn a lot. So teaching is part of what we are doing, so that students all over, not only Ugandan students, it's now International Learning Center. Then two, when some of these technology companies, you know, example of Sonosite, when there is a big change, you know, as a result of what they have done, it's a marketing tool for them. So to us, we don't really, the only technology that is difficult is, you know, where people donate and then eventually they break down and nobody to, you know, service them, all that kind of. That's why you start with the training. People first learn how to use the technology, how to service the technology, and then everything is done by us. Yeah, so that is local capacity building.
As a follow-on to that, technology question. So earlier today, you and I were talking about telemedicine. Could you share a little bit about possibilities for telemedicine that you're exploring with?
Yeah, I've actually traveled 42 states out of, you know, in the US. Not this time, but in the last 10 years. So I've gone to very many places. This year, one of the places I was in 2 weeks ago was Mayo Clinic. I went there last year. They invited me, and then some discussions have been going on. So this time we are conducting seminars with them. So Mayo Clinic is looking at developing, they have that program of Mayo Clinics abroad. So one of the easiest ways of establishing those clinics is telemedicine. So, and they have looked at our project and they think it is worth partnering with. So now, I think in about 2-3 months' time, someone will come to do needs assessment. And if Mayo Clinic establishes telemedicine, I mean, now we can consult experts, you know, remotely. People don't always have to go there. And then that one will also help students. So then we will also design some of the programs where students don't have to go there. How can they learn from? So these are all different ways we are exploring. When one partner comes, then how do other partners benefit from that? That is our approach, so scaling it up. Yeah.
How is public education in Uganda in terms of helping people do more and better family planning? Is this being taught in public schools? Are people receptive to this, or do people feel threatened by this idea?
Okay, no, people are very receptive because we have done a lot of education in the communities. You know, you have a film, a typical example, like, you know, a family, you have scenes where there are two families. One family has 2 children, another family has 10 children, and they have the same quantity of food. Family with the 2 children, they eat while talking, discussing. Family with the 10 children, they are fighting for food, they are also hitting one another, you know, because food is, people laugh, it is fun, but the message goes in. So everywhere, big family issue is now becoming like abnormal. So which means people are taking up family planning seriously.
And that's being tracked with metrics?
Now, that's why we need them. We need the universities with the metrics, because you see, for us, we are implementation organization. You are implementing. Now, I always tell people we are doing firefighting. We are fighting fire. You see, when the house is on fire, you want to put the fire out. You are not going to say what caused the fire. You will not save anything.
What will the fire look like next year? Yeah.
So now, that's why I say, let the universities come. All this work we are doing, how can we design data collection tools? Because even when we go to the communities, we collect data. But then it is basic data. If we design a very good data collection tool, then the data is systematically collected and it can be analyzed. Then it becomes easy to follow these metrics. Yeah. Really, that's why we need the faculty members. We need next time to come here and talk data metrics. It doesn't help me to come here every year talk about the same thing. We want, what difference has been, have we made as a result of Princeton coming to Uganda. The next talks will focus on that. But to make that, we need to have a study. It has to be scientifically designed, it has to be approved, it has to be published. You can see those protocols. That's why my approach there too. Students come and learn fine, but then how do we involve the faculty members to do the metrics? You have asked the right question. So how do we do the metrics? We are doing firefighting, but then the fire is going to come. So you design a system for the metrics. Yeah.
Excuse me, thank you for coming. Big time stuff, what you've done. Really admirable. I'd give you $10, but right now I got to go to the Mac. I don't carry much cash. You have relationships with UW, University of Washington, SC, CLEC. Where's the funding? I'm looking here at some of the richest Ugandans, and I see Sudhir Raparilia. Are these people on board? Who's on board? Where's the backing? I have a call in expecting to hear from the president of the Geraldine Dodge Foundation. Where's it coming from? Who's supporting you guys?
Actually, that is always the biggest questions people ask. Working with the communities, we don't actually have a major funder. We are working with the communities. We are raising 70 to 80% of the resources we raise on our own.
Where's the government?
That question is very complicated. The government is there, but they're giving us medications for HIV, but definitely it's not enough. But you see the current discussion even in the countries, we are doing such a great job, so we need more help. So, for us, we don't really want to be like, more in activism, advocacy, They are talking bad about government. No, government even accepts there is corruption. So many times when you get money, you see there's a bureaucracy. They can say, okay, we are giving you $1 million. You see, so but you see it is from a higher level. By the time it reaches you, it may be $5,000. That's another problem. If you don't understand corruption, that's how it works. They allocate 1 million, there is pilfering, it keeps disappearing. And you are forced to talk that you received 1 million. So that's why at times you leave them, you leave them alone. Do your own things, whatever they give you. Actually, when they give us pills and other supplies, it is better. But our partnership with university is getting very useful. Students are writing.
What about these billionaires, the money man back there? What about the U.S.? Where's their funding?
Now, that's why I say make noise. Because when you make noise, eventually the noise will reach some of these people. Students have been making a lot of noise, but then some of those, the reason why some of the noise is becoming popular is because of publication. Our work has been published twice in New York Times. This time it was almost 3 pages. A journalist came there, went with us. It was like, this is unbelievable, you know? So Bill Gates Foundation has just invited me for a talk. I don't know what will come out of it, but it is in Spain. They are convening a meeting in Spain. But you see, we have to keep making noise. For us, we are saying, we are not going for the big people. That's why I say this bus is 100,000. Let's look for 10,000 people, only $10. Our rabbit project, let's do evaluation. Let's see how it is helping in the nutrition. The metrics, what is saying? How do we do the metrics? That's where we need the universities.
Have you ever worked with the Global Fund to fight AIDS, TB, and malaria?
Global Fund works with the Uganda government, and we get the support through the government. So all the TB medicines we get free, all the HIV medicines we get free. In the last 4 years, American government has supported us to reach more sites in the rural areas. Slowly, people are getting to, but you see, there's a small grants. We are still getting small grants. But you see, universities, other people look at, no, these people don't need small grants. They need the big grants. But we hope to reach there one time. Yeah, let's just build on. If we get this bus, we reach to very many communities. And then people are like, no, we need to help them. Yeah.
Professor, can we get the students involved here?
Well, I would say, do any students who have been there have anything they want to share about their experiences? I think a few people.
Well, I mean, in terms of the fundraising, can we spend half a day and, you know, Penn State goes out there, puts buckets, can we do
So the
something?
university wouldn't put its resources behind that campaign, but students would always be welcome to, and do regularly, initiate fundraising campaigns.
Well, I mean, solicit the community, solicit us, wherever.
Right. Students could certainly do it. There's nothing stopping students from doing that. But yeah, I leave it to you. Like, students, do they have anything to add or to comment on that or anything related to Dr. Anguyo's presentation?
I think one thing I definitely took away from my time there, because I spent a summer there just shadowing the doctors, hanging out with Dr. Anguyo and just seeing like the work he's done. It's a very large like community. Like they all treat each other like family, really trying to support each other in all the clinics. It's really cool how like there's different like clinics. Like there's the HIV clinic, and then right next door is the general clinic. And so like the children like from the doctors of the HIV clinic, we like run around and hang out with like everyone else. So it's like a very big family there in GF, and I think that's what really works because everyone supports each other in like the best way possible.
In terms of like fundraising, I think groups of students have done things like on our own. The summer we were there, the whole cohort of students that summer, we did a just like a GoFundMe campaign for the maternal delivery kits, and I don't remember how many we made. We raised like a couple $1,000s just from our own networks, but that wasn't something through the university. That was
No,
just
of
all the
course.
students there.
Yeah. Great.
There are sometimes student interns, not with this program, but with others that I've seen. I've worked with a lot of people on internships and fellowships that do grant writing internships, where the thrust of their work there is grant writing and raising funds through larger donors for the host organization. So that connection I don't think has been made with Geoffrey per se, but that is an area which perhaps they could explore too, getting somebody that's connected in the whole grant writing world to do some heavy grant writing lifting for them.
Do we have doctor's contact? Do we have a way of reaching him?
Oh, definitely.
Yeah, I have business cards here. And of course, one of the things also we are looking at, there was a major contact here, a faculty member who eventually got another job in San Francisco. Now, some of these students are graduating. Another question is, how are we going to keep in touch with the university? So those are also questions. Who is the main contact person as a faculty member? So those are Those are some of them. Yeah, I have cards here. Of course, things always have to get started. One person starts and then others build around. You said, I already have $10. Then another will say, I have another, you know. So the issue is who collects them. And you know, I was in Salt Lake City, that was the same case. People say, I have the $10. So the issue is who is going to collect. Because we are saying when you collect, send to SafeHI. Then you talk to other people. Some people may need a tax receipt. Someone may need to donate $500 or $1,000, needs tax receipt. They still get from SafeHI. So the information has to be clear. But if we can have someone who can collect, eventually, the reason why we do that is, you know, we also want publicity. Say, no, we got this much from Prince, and we got this much from this, we got this much from this. We only want that platform to be created.
Yes.
I'm just wondering how your work in Uganda has impacted other East African countries. Like, for example, I spent the summer in Tanzania, so would I have seen any of like the stuff you're doing in Uganda, like, in these other countries around you?
Yeah, I was invited in Tanzania in March this year, so in Dar es Salaam. So it was a big conference, and they wanted me to talk to their people. So that is, I was invited to Ghana. So they brought the University of Ghana, they said, you know, people have to listen. So now I'm moving to different African countries. Like I said, you know, people are welcome, many people come to see what we are doing. The issue is, how can you do it there? Yeah. It needs a lot of commitment, it needs a lot of engagement with the people. You know, you have to engage communities. If you don't have good relations with the communities, then you fail. Yeah. For us, we are non-denominational. You know, we work with all religious organizations, with all art organizations, with the government. We work with anybody, unless if you don't want to work with us. So we also have that freedom. Yeah.
Have you reached out to Matthias Kiwanuka? Do you know he used to play football for the New York Giants? He could help you get this $100,000 in a month.
Of course, now we need the people who can reach out to them. If
how about someone in the Ugandan community or the African community? I don't know what Kiwanuka does. He's out of the league, but he could get you this $100,000 by the end of the year.
Yeah, but that's what we are trying to do. How do we reach?
It's a lead for you.
Yeah, that's very good. That's a very good information. Yeah.
He probably still lives locally. He went to Boston College. So there's a lot of money in Boston. There's a lot of money in New York. There's a lot of money here in New Jersey.
Yeah.
He could get you that money within 30 days.
I'll be with a good friend tomorrow that knows the Gateses.
Yeah.
I mean, is that too big? I have a call into the Dodge Foundation as well.
I mean, let's the discussion keep flowing, and we see what can work. Yeah.
You're open to that kind of?
Yeah, very, very open. Very, very open. Yeah. We don't lock out any opportunity. Yeah.
If we could see our president's tax returns, you probably could get the money from him.
Okay, so on that note, to wrap up, thank you all for coming, and especially if you can give a vote of thanks to Dr. Anguyo for his presentation. You're welcome to stop up at the end and give a few more comments or chats if you like with Dr. Anguyo. How did you do it?
And we talk about African corruption. We're in a class of our own.
Yes, thank you for coming.
Are they still doing that?
Welcome. Yes.
Okay. Gotcha.
And then the rest are all.
Okay.
Yes, thank you.
Actually, that's something we have addressed very well. I think
Sorry, I'll go with you. I'll walk over here.
so
I think
that's
that
fine.
we got him over here from the hotel this morning. I'll stick around until he's.
Okay.
I will hopefully turn this off.